Hi everyone. So today we are going to talk about monitoring and mapping of the cranial nerves. Which is very critical for various surgical procedures which involve cranial nerves of the brain, including the brainstem and fourth ventricle surgeries. So the objective of today's presentation is to identify the different techniques which are used for monitoring each cranial nerve and different type of modalities we can apply for these nerves, because some nerves are sensory nerves, some are motor nerve, and some of them are mixed sensory and motor nerve, and also the pitfall of their monitoring and their prevention, how to make sure everything is going fine. So removal of the brain tumor around the cranial nerves is very challenging even in the modern day with all the new technologies. The morbidity and mortality is directly related to the level of radical resection. Intraoperative neurophysiological monitoring or surgical neurophysiology has been presented and has documented that it gives us a very good feedback in real time during these surgical procedures, and it helps in reducing the post-operative neurological deficit. By utilizing intraoperative neuromonitoring, a neurosurgeon can improve the patient outcome and minimize the morbidity. It also helps in accommodating more complex surgical procedures and minimizing any post-operative deficit which are related to damage to these cranial nerves. So when we are doing monitoring or mapping of the cranial nerve, we have four major goals. The first one is to identify the nerves. So this is a tumors or any aneurysm or arteriovenous malformation, or we are doing microvascular decompression, any procedure we are doing around the nerves, we want to identify the nerve before we start doing resection or doing the procedure. Even when we're doing the surgeon is doing the procedure, we want to keep identifying the nerve and tracking the nerve where it is leaving. So the second is tracing the nerve. So we want to trace the nerve into the tumor to see if the nerve is going to the left, medial, lateral, anterior, posterior, superior, or inferior, because all these different type of tumor can push these nerve fiber to different direction, which are not in the course of their normal anatomical location. The third point, the goal is to protect the nerve during these neurosurgical procedures and make sure the patient doesn't wake up with any deficit to these nerves. And at the end of the surgery, when everything is done, to confirm the integrity of the nerve before we start closing the exposure. So the four main goals of monitoring and mapping of the cranial nerves in these surgeries is to identify the nerve, to trace the nerve, and to protect the nerve during the procedure, and to confirm the integrity of the nerve at the end of the procedure. So as we know, we have 12 pairs of cranial nerves. They are labeled as cranial nerve 1 to 12. We always label them in Roman numericals. So the cranial nerve number 1, it is olfactory nerve, which is responsible for smell, and it has no motor function, and it's very hard to monitor in the operating room because of saturation. So the smell saturates, fiber saturates very quickly. So there's a possibility, there are publications that we can stimulate and the nasal fibers, and we can record a response generated on the cortex. But under the anesthesia, it's not possible, and we usually nobody monitor olfactory nerve. So all the other nerves from 2 to 12 we monitor. So the second is optic nerve, which is a sensory nerve responsible for vision. So we monitor by visual evoked potential. Cranial nerve 3 is an oculomotor nerve, which has no sensory function. It's a pure motor nerve, and we monitor by EMG. And EMG trochlear nerve is also a pure motor nerve, fourth cranial nerve, and we monitor by EMG, spontaneous and trigger. Trigeminal nerve has a sensory and motor, so it's a both component, and we can monitor by trigeminal SSEP and also motor evoked potential and EMG. Abducent nerve is a cranial nerve number 6, which is also motor nerve and has no sensory component, and apply the muscles of the eye, and we can monitor by EMG. Cranial nerve number 7 is a facial nerve, which is the most common nerve monitor around the world beside cranial nerve 10. Vagus nerves 7 and 10 are the most common nerve monitor in all the cases. So facial nerve is a mixed nerve which has sensory component and motor component, and it is also responsible for taste, your lacrimation, saliva, and facial muscle of the facial expression. So facial nerve is monitored by EMG, SSEP, facial SSEP, and also corticobulbar MEP. Cranial nerve 8 is vestibulocochlear nerve, which is a pure sensory nerve and responsible for hearing and balance. So vestibular part is for hearing, vestibular part is for the balance, and cochlear part is for hearing, and they both combine and form the vestibulocochlear nerve, and this is being monitored by auditory evoked response or brainstem auditory evoked potential. The next nerve is cranial nerve number 9, which is glossopharyngeal nerve, and it has sensory and motor function. The sensory function is the taste of the posterior 1/3 of the tongue, and then we have muscle movement in the soft palate and stylopharyngeus muscle, and is monitored by motor evoked potential, which is corticobulbar MEP and EMG. Vagus nerve is cranial nerve number 10, which is also the most common nerve monitored beside the cranial facial nerve, and it has the longest nerve in the body, and it's responsible for some part of the taste in the posterior pharynx, and also the motor function of the vocal cord. We monitor by EMG, corticobulbar MEP, the vagus nerve. The 11th cranial nerve is a spinal accessory nerve, which is also pure motor nerve. It has no sensory component. It supplies the trapezius muscle and monitored by corticobulbar MEP and EMG. The last nerve, cranial 12, is hypoglossal nerve, which supplies the tongue, and it has only motor function and monitored by EMG and corticobulbar MEP. So if you look at the base of the brain, so we can see all these cranial nerves from anterior to posterior, and if you have done any cadaver dissection, then you can lift the frontal lobe, and then you can see the olfactory nerve, and then if you cut and you lift more, you get the optic nerve, and if you cut the optic nerve, you can see the cranial nerve 3, 4, 5, 6, 7, 8, 9, 12, and they go back. So the largest nerve is the trigeminal nerve, which is the 5th cranial nerve we can see in the midbrain. So we have in the skull, we have frontal anterior cranial fossa, we have middle cranial fossa, and posterior cranial fossa. So the frontal lobes is in the anterior frontal fossa, the temporal lobe is in the middle with all the lower cranial nerve, and the lower cranial nerves and cerebellum is in the posterior cerebral fossa. So again, cranial number, I'll go to each cranial nerve one by one and describe that. So the cranial nerve 1 is olfactory nerve, which the fibers originate from the nasal mucosa, and they go up to the cribriform plate of the ethmoid bone, and they form the olfactory bulb above that and superior to that, and then we have olfactory tract. This nerve, it can be stimulated, and it creates a peak, but it's not monitored by in the intraoperative because of its quick saturation. If you try to smell anything, like if you have 2-3 things and you want to smell, and after a few minutes you will not be able to differentiate because your nasal fibers or the receptors, they get saturated very fast. So optic nerve, second nerve, is responsible for vision, and as we see that it has multiple fibers and more complex than other nerves. So the origin from the retina, and the retina, we have medial nasal part of the retina and the temporal part of the retina. The nasal part, half of the retina, is toward the midline, and temporal is more lateral. So the nasal part of the retina, they travel back and they cross at optic chiasm. The crossing of this, so they form the nasal fiber and the temporal fiber, they combine, they are known as optic nerve, and then optic nerve cross at optic chiasm, but in that crossing only the nasal fiber cross, the temporal fiber, they stay at the same side, and then they go to lateral geniculate nucleus in thalamus, and from the lateral geniculate nucleus you have optic tract or optic projection, and they go and they make a synapse in the visual cortex in the posterior occipital lobe. So the temporal fibers of the optic nerve, they are projecting the nasal visual field, so midline, and the nasal fiber, they are crossing, so there's a cross, so they're projecting the other side. So we can stimulate, we can use the optic nerve stimulation or visual cortex during different types of surgery, especially involving the frontal lobe, which could be the optic nerve tumor, it could be optic chiasm, or pituitary tumor, or ophthalmic artery aneurysm, or tumors around the frontal lobe. So we use the goggles, which are LED goggles, and stimulate with the flashing light, and then we record the signal from the occipital lobe. In the awake patient, we can do two types of stimulation. One is called checkerboard, and the other one is called flash LED, which is the goggles. So, but for the checkerboard, they are black and white square boxes on the screen, and in the middle of the screen there's a point where the patient has to focus, and we stimulate either the whole eye retina, half of the retina, or quarter of the retina, and we can identify if there's a change or problem with any, even quarter or half or the full retina. So if you look at the VEP responses, we can see on the left side, we can see the main responses are N70, P100, and N145. So P100 peak is recorded from the posterior lobe, which is the occipital lobe, and take 100 milliseconds to get there. And that's the peak we want to look at the stack to see if there's a changes. We can also record from the retina, which is known as electroretinogram or ERG. The ERG is electroretinogram, and it's about 35 milliseconds. So N35 is the response we record for that. We can have record by using the contact electrodes. So the contact electrode, they can be placed on the cornea, and their eyes are closed, and then you place the goggles on that. So if you use those contact electrode, we have to make sure the patient has gel on the contact, so they're not touching the cornea directly, so because they can cause abrasion and laceration and damage to the cornea. So this is a paper we published about the technique, about the visual evoked potential. So if you want to go more into detail, so this is a nice article which tell you about all the modalities specific to visual evoked potential. So the next we go to the nerve which supplies the three nerves which supply the muscle of the eyes. So there are 6 muscles in the supplying the function of the eyeball, which are 4 rectus and 2 obliques. The rectus is superior rectus, inferior rectus, medial rectus, and lateral rectus. And then we have superior oblique and inferior oblique. So the lateral rectus is supplied by cranial nerve number 6, which is abducens nerves, and when it contracts, it moves the eyeball to the outside. Medial rectus is supplied by cranial 3, superior rectus, inferior rectus, and inferior oblique. So those are the 4 muscles which are supplied by oculomotor cranial nerve 3. So if the medial rectus contracts, the eye moves to medially toward the nose. Superior oblique, it elevates the eye. The inferior rectus, it depresses the eye. Inferior oblique, it elevates the eye and turns outside laterally. And superior oblique, which is supplied by the third nerve, trochlear nerve, cranial nerve number 4. When it contracts, it depresses the eye and turns it laterally. So those are the 6 muscles of the eye and supplied by the 3 nerves, cranial nerves. So here we can see the cranial number 3, oculomotor nerve, which is interpreted, can be monitored by EMG, spontaneous and trigger EMG, supplying superior rectus, medial rectus, inferior rectus, and superior oblique. It also supplies levator palpebrae superiorus muscle and superior rectus muscle and superior oblique. Superior oblique is supplied by cranial number 4, so that's not supplied by that. And so cranial number 4 is superior oblique muscle, and when it contracts, it moves the eyeball downward and lateral, and intraoperative monitored by EMG by placing the electrode in superior oblique. If there's a dysfunction or damage to the trochlear nerve, it is a loss of the downward and inward movement of the eye, and patient will have disconjugate gaze. The third nerve, abducens nerve, supplying the eye is abducens, which supply the lateral rectus, and when if there's a damage to the lateral rectus, patient eye will be deviated to the middle, to the nose. So for electrode setup, the needles electrodes can be placed with the bent needle. So you have to make sure we are not placing the electrode inside the eyeball, and it needs a lot of practice and has to be done under the supervision with the senior neurophysiologist before you start doing that. There are many people, they refuse to do that, and it's very hard and risky but with appropriate technique and placement, we have no problem. You can place either two 90-degree bent needle, or you can place one needle and reference to reference electrode, which is placed against the forehead on the opposite side. The ideal electrode which should be used is called hook wire electrode, and they come in single and paired. So if you place the hook wire electrode, they are very fine and they don't pick up too much far field response. So they have good common mode rejection, and here we can see that we are placing the percutaneous hook wire electrode using a 24 gauge needle, and so you have to press the eye and move the eye away from the needle and direct the needle upward and toward the bone and insert the needle. So once the electrodes are placed, so this is how it looked like for cranial setup 3, 4, and 6. And if you have any spontaneous EMG, we have this spontaneous EMG activity which can be seen in cranial 3, but not from 4 and 6, which are still very close but very specific recording from. This is the sample recording from these cranial nerves by stimulating trigger EMG, and the latency of the medial rectus and the lateral rectus is very short as compared to superior oblique and facial nerve. So EOG is another technique which can be used for the eye movement, electrooculography. You can place the electrode on outside each eyeballs or outer canthus, and then when the eyes are moving, we can see the deviation on the slit. So we see slow waveform which shows us on the screen. So this is again placement of the electrode. So from Kaya et al. Published in 1999, the placement of the positive and active. And when you're stimulating or you see the movement of the eye, contraction of the eye, we see deviation and we know is it a positive response or negative response. The recording electrode we use for EMG either can use as referential and bipolar recording. Referential recording are more sensitive but less specific. Bipolar are more specific but less sensitive. So bipolar are superior because they also have less chances of picking a far field response, which may give a false negative data. Stimulation electrode, we can use monopolar or bipolar electrode. So the monopolar stimulation are more sensitive. Again, bipolar less specific. Monopolar we use for the cranial nerve, we use flash tape or sharp tick electrode. For bipolar, you have bipolar concentric or bipolar side by side. So you can use either of those two electrodes. The edge test is a clinical test which is used for, you ask the person to go up, down, left, and right. And then on these, if the patient can move up, down, left, and right, we know that all the cranial 3, 4 are okay. If the patient has, these are the examples of the palsy of the third nerve. So, for example, if a patient has aneurysm or vasculopathic tumor, it might affect the third nerve, and which will result in the deviation of the eye. The fourth cranial nerve will, due to tumor or congenital trauma, will also affect the superior oblique muscle, and the sixth nerve, which is also affected by cranial nerve pressure or a tumor, and can sixth nerve supply abducens nerve supply the lateral rectus. So if that is damaged, the eyes will be deviated to the nose or nasal division. The next nerve we will talk about is cranial number 5. So which is the largest cranial nerve and the mixed nerve. It has 3 main branches. It comes out from the each branches come out from different foramen in the skull, and then those are known as ophthalmic branch, maxillary branch, and mandibular branch. The ophthalmic branch is also known as V1, V2, and V3, and V stands for 5 in Roman. So V1, V2, 3. So V1 ophthalmic branch supplies the forehead up to the angle of the eye. Maxillary branch or V2 supply from the angle of the mouth to the angle of the eyes, and mandibular branch supply of the face and the neck area below the angle of the mouth. So these are the sensory distribution of the trigeminal nerve. So the motor function of trigeminal is monitored by placing the electrode into either masseter muscles and temporalis muscles. Those are the two muscles, and we can do EMG from there. So we can do trigeminal SSCP. So trigeminal SSCP is done by placing the electrode on the gums, either upper or lower gums, or you can put it on the upper and lower lips, or upper and lower reference to each other, and stimulate it. It produces a lot of stimulation artifact. So to get rid of stimulation, either you can use a bipolar stimulation, or you can alternate 50 stimuli with positive and 50 with negative. So facial nerve number 7 is facial nerve, and it's also known as muscle of the facial expression. So all the muscle of facial expression, it supplies salivary secretion and tears production and taste of the anterior tooth or the tongue. It intraoperatively can be monitored by EMG and corticobulbar MEP. It has 5 major branches: temporal, zygomatic, buccal, mandibular, and cervical branch. And these 5 branches supply multiple muscles. Like the temporal branch supply the frontalis muscle, the zygomatic branch supply with orbicularis oculi, buccal branch supply the buccinator and zygomaticus, the marginal mandibular branch supply the mentalis muscle on the chin, and cervical branch supply the platysma muscle on your neck. So we monitor all these nerves, especially for parotid tumor, because the nerve enters the parotid gland and then it's split into all the branches, and then it supply all the muscle of facial expression. So if it's a parotid tumor, you have to monitor all of them. If it's a brainstem tumor, then 2 or 3 branches should be enough, because the surgery is on the main trunk, not on each branch. But anything has to be when all the branches are affected, especially for parotid gland tumor, then we have to monitor all of them. So these are the branches, 5 branches, and the muscles supplied by these branches. So if we can also recommend to do mapping of the skin. So before we start the surgery, so you can stimulate with the handheld stimulator, monopolar, and stimulate at high current and get a response. And when you get a response, the surgeon can mark with a marker that these are the branches before they go dig into the tumor. So for the placement of the electrode, so we need to have a good placement of the electrode from frontalis, oculi, oris, mentalis, and platysma. Then monitor all the branches and the muscle innervated by these branches, and we do stimulation. So we should not rely on only spontaneous EMG, because spontaneous EMG can be misleading. It may not fire anything. So if there's an irritation of the nerve, damage to the nerve, it may have any train activity or burst activity or nerve activity. So to make sure we are on the nerve and make sure that we are not damaging the nerve, it's better to stimulate either trigger EMG and corticobulbar MEP. So if the patient has any abnormal responses, it could be burst activity, spike activity, neurotonic discharge. Here we can see train activity and both upper and lower. So it's more like a train, which is higher than 40-50 hertz, and A train. So A train in the research has shown that the A train is associated with postoperative facial nerve deficit. So and the length, the activity length is contributed to 10 seconds. So is there 10 seconds? If this activity lasts for 10 seconds or more, there's a high probability the patient will wake up with a deficit in the facial nerve. So you have to inform the surgeon immediately and make sure they reverse, and then they do warm irrigation or something which can resolve that train activity. Stimulation of the facial nerve at the brainstem to create a response which peaks around 7 milliseconds. So and that is a criteria for identifying the facial nerve and differentiating from the cranial number 5. We can see on the right side on this picture, the responses in the box with all the facial nerve, and a response in the trigeminal nerve, which is the first one on the top left picture and the second one on the right picture. The responses from the trigeminal nerve, if you stimulate the trigeminal, is about 5 milliseconds, but the responses for the facial nerve occur at about 7 milliseconds.